Hello, everyone. I want to thank you all for joining us today for this Karius webinar presentation, Uncovering Infections in Transplant Recipients with Liquid Biopsy, the Clinical Utility of Plasma Microbial Cell-Free DNA Metagenomic Sequencing in Solid Organ Transplant Recipients. My name is David Berman. I'm a pediatric infectious diseases specialist and senior medical director here at Karius. Before I proceed to the introduction here, just some housekeeping. If you have questions during this presentation, please feel free to put them into the Q&A. We probably will be getting a lot of questions, but we will try to answer as many of them as possible. And if we don't get to your question, we can follow up with you offline. There's going to be three parts of this talk. I'm going to give an introduction to the Karius test for those of you that are not familiar with the technology. I will then introduce our speakers, and then we will follow up the third part with a Q&A, focusing on the plasma test. Our lab is located in Redwood City, California. We have one site where we do testing. So you obtain that blood sample from the patient, and we are looking for microbial cell-free DNA within the plasma space. We can detect over 1,000 pathogens, and we report out on those. And once we receive the specimen, the turnaround time is within 1 day. So you usually get the results the next day, and that will come out as a report in your EHR, or for some of you that have access to the Karius app on your phone, you can get the reports that way as well too. So a little bit about this technology. Some of you may already be familiar with cell-free DNA technology used in prenatal diagnosis, transplant medicine, as well as hematology oncology. One of the challenges with microbial cell-free DNA, as you notice there, is that very small fraction of it, which is actually present in the plasma. So that's where we leverage our technology to detect bacteria, viruses, fungi, and parasites, DNA microorganisms from the plasma. And one advantage of our test, besides the rapid turnaround time, is the broad range of human pathogens, which we put onto our report as a minimally invasive technique of finding these microorganisms. So we're looking for deep-seated infections, difficult to diagnose infections in patients with a high pretest probability. I have here listed many different microorganisms in different parts of the body and different organ systems. One thing I also want to point out here too are not only just obligate and opportunistic microorganisms which we can detect, but we can also detect commensals which have the ability to cause infections as well as the DNA viruses. Additionally, we have the ability to speciate microorganisms, which becomes really important, as many of you know on this call, in solid organ transplant patients, particularly for organisms like Karius species and invasive fungal infections, where having that species identification early can help guide your treatment. So the diagnostic applications are broad, and as you can see here, a lot of them will cross over to different categories. We have a primary focus on immunocompromised patients, but the test can be used in immunocompetent patients as well too, with pneumonia, invasive fungal infections, patients with prolonged fever, endocarditis, zoonotic and vector-borne infections, focal deep-seated abscesses, osteomyelitis, and select patients with febrile neutropenia. Over the last few years, this technology has been highlighted in some guidelines, including the American Society of Transplantation and Diagnostics, the American Society of Transplant Cellular Therapy and Non-Aspergillus molds, blood culture negative endocarditis, the American Heart Association, and a recent guideline of HIV, Health and Human Services in adolescent and adult medicine, highlighting the technology used in Bartonella infections and Mpox. So it is my pleasure to introduce our speakers today. Both of our speakers are from Baylor St. Luke's Medical Center in Houston. So we're going to have two speakers today. Dr. Sohail is a professor of medicine and infectious diseases, adult medicine at Baylor College of Medicine, and a medical director of the faculty group practice. He's also chief of adult infectious diseases at Texas Children's Hospital. He completed his fellowship at the Mayo Clinic College of Medicine, has a strong interest in cardiovascular infections and developing prediction models and risk scoring systems. He's authored over 200 peer-reviewed papers and 29 book chapters on cardiovascular and healthcare-associated infections. Dr. Khalil is an assistant professor of medicine and infectious diseases at Baylor College of Medicine and co-director of transplant infectious diseases at Baylor St. Luke's Medical Center. She completed her fellowship in ID at the University of Michigan and her transplant ID fellowship at the Mayo Clinic in Rochester. Her research interests are cardiovascular infections, molecular diagnostics in transplant patients, and currently leading two large nationwide registries on infections in solid organ transplant and cardiovascular infection as a principal investigator. I'm now going to hand over the microphone to Dr. Khalil.
All right. Thank you, David, for giving the background of the test and introducing us. We are really excited to hear to share our experience in the seminar today. And we think this is a great opportunity for all of us to learn and hopefully, go home with some points that will help us how to use this innovative diagnostic test. Here are our disclosures. Next slide. So we'll start with some cases. The first one is a really interesting case of a 33-year-old female who underwent a lung transplant in 2017 for cystic fibrosis. And she came to our hospital recently with acute onset of right-sided headache, right-sided vision loss, difficulty speaking, and some weakness. And so she had an MRI done, which showed a right MCA stroke, also had a fundoscopic exam with findings concerning for optic neuritis. And so the team went ahead and did an LP, and the CSF showed a high white count of 145, almost exclusively neutrophilic with 0 lymphocytes, mildly elevated protein at 68, glucose of 84. She had CSF stains and cultures which were negative. Just some other pertinence in her history, she recently had coag-negative staph bacteremia, which was high grade, and finished a prolonged course of IV antibiotics a couple of weeks ago. Also recently moved from Arizona 6 months ago with her cats. No other exposure histories other than your regular mosquito bites. So if you come across a case like this in your practice, what would be your next step in approaching this patient? Would you, do a meningitis encephalitis panel, or would you do serologies for West Nile, syphilis, or Bartonella? Or would you, go ahead and order a Karius test? Or you would think that maybe this looks like crypto, we should do serum or CSF cryptococcal antigen and start the patient on IV amphisome. So please go ahead and vote. We won't give you the answer. We'll come back to it at the end of the presentation after, what we discussed, and have you vote again and see if, this helps change your management in terms of diagnostics.
So this is a 52-year-old female with history of deceased donor kidney transplant 3 years ago. She has history of recurrent UTIs and frequently gets prescription of antibiotics to treat those. So this time she develops another episode of what seems like cystitis to her. So she calls the primary care, who advises to get a urea and urine culture and sends a script for ciprofloxacin. Unfortunately, like many of our patients, she does not go to the lab and get the culture done, but starts the antibiotic anyways. Over the next few days, while symptoms of cystitis are a little bit better, but they're not gone, and now she's developed a new acute back pain and ongoing low-grade fevers. So she's hospitalized. Admission labs show white blood cell count of 13,000. Blood and urine cultures were sent on admission, which are negative on day 2. To investigate the new back pain, and MRI is done, which is suggestive of L4, L5 discitis / osteomyelitis. So in this patient who has had recurrent UTIs, frequent courses of antibiotics, now comes with suspected spine infection, what would you do? Initiate empiric antibiotics, thinking that the history fits with the bacterial osteomyelitis, and you're not going to have positive cultures because of prior antibiotics, or go ahead and try to convince her to get IR-guided biopsy anyways and send it for bacterial cultures. Option 3 is send Karius because you anticipate negative cultures, so that is the next step, or wait, and only if the spine biopsy cultures are negative, then send Karius. And these are not like right and wrong, yes and no answers. These are basically your approach to what would be the next best step. So please vote now.
All right, so before we get into the relevant studies, I briefly want to talk about the Karius report. When we look at this slide, there are 3 things that we need to pay attention to. So one is the organism on your left side. The second is the NPM, which is your quantification. And the third one is your antimicrobial resistance markers. And we'll discuss each of them separately. So the first thing is the organism. And the report separates them out into 3 distinct but clinically relevant categories. So the first one in the red box here is your obligate and opportunistic pathogens. These are almost always in majority of the patients pathogenic. And so if you send Karius for a specific syndrome of concern and the the organism that you get, which is your obligate opportunistic pathogen, it doesn't fit the reason you sent it for, then it means that it's something else is going on as well, in addition to this primary syndrome of concern. And so they should not be ignored or designated as irrelevant. So they warrant further investigation and to be acted upon. The second category of organisms is the one in the yellow box. And these are well-known pathogens in humans, but can also be, commensals and colonizers, and therefore they require some sort of interpretation. And this is where really your MPM can be helpful to put the organism load in context with the presentation. So then lastly, the third category of organisms that Karius picks up are usually not of clinical significance. They occasionally might be, but usually subject to case reports. And they account for less than 1% of the pathogens that Karius reports. But because they're not that common, they can be frequently contaminants. They require a very careful interpretation in context with the clinical syndrome. Then the second thing is in the center of the report, which is your MPM's molecules per microliter. This is your metagenomic version of what you would consider like bacterial or viral load, basically your quantification of the organism. And in this category, it can be useful, one, to assess the importance and significance of the organism, but also in some select circumstances in serial monitoring, which we'll discuss later too, basically see if the load is going down in situations where you don't have other clinical parameters to assess response. And then lastly, which is something relatively newer, is looking at the antimicrobial resistance markers, which is on the right side of the report. So Karius can detect up to 7 antimicrobial resistance markers based on its current performance across 18 bacterial pathogens. So this is relatively newer, introduced probably, I believe, in the last year and a half, and can be really helpful in situations where the patient's been on prolonged antibiotics, you don't have any cultures to look at susceptibility patterns. So it'll give you some information guiding you on what antibiotics to use in that patient population. So once the patient's transplanted, post-transplant, we want to look at the risk profile. And this is something that's not a static thing, but it's a dynamic picture which changes over time. So, based on where the patient is, their immunosuppression, their exposures, the risk for different infection varies over time. And it's mainly divided into 3 time frames: early, intermediate, and late. So firstly, early is typically the first month post-transplant. Here you see a patient, who's just gotten the transplant, they're in the hospital, which may be for 1 to 2 weeks or longer, depending on their situation. So what kind of infections would you anticipate in these patients? So in most cases, because they're in the hospital, it's related to the surgery they undergo and then being in the hospital. They have a central line in place, they have a Foley catheter, so UTIs, CLABSIs are common. If they're on the ventilator and just being in the hospital-acquired pneumonias and your ventilator-associated pneumonias are common. And these are usually your typical bacterial infections, which are readily culturable. So, really Karius wouldn't be the route to go down with this kind of infection risk that you're looking at. There are 2 other distinct and important aspects unique to the transplant patients, which are your donor-derived or recipient-derived infections. So when you really think about those, they can be bacterial, herpes virus groups, parasites such as toxo, chagas. And so now majority of these are detected in the pre-transplant screening of both the recipient and the donor. So there's already strategies in place to prevent them from happening. So they're not really something you're going to see early in the post-transplant period. However, sometimes the donor recipient can have some hidden infection, which may surface with heavy immunosuppression that you didn't anticipate, and they can get really sick. So you send all these conventional testings and you don't really know what's going on, they're negative. So in that small subset in this period, really doing Karius testing may be helpful. So once after the first month, if the patient survives, which we usually expect them to, there's a transition from hospital to home. And their immunosuppression also transitions from induction to maintenance immunosuppression. And the risk profile also starts to change. They're in the community, out and about in the environment, so they're at risk of community-acquired infections, and then at risk for atypical infections like mold and fastidious organisms such as NTMs, nocardia, which you wouldn't really, are readily culturable. However, in this first period in the left, from the 1st to 6 months of post-transplant, you don't really see patients manifesting these because they're on prophylaxis. So if they're going to be on Bactrim, you're not going to see toxo or PCP. If they're on voriconazole or POSA, you're not going to see a lot of fungal infection. So these presentations are usually delayed. And as the patient moves beyond the 6-month period and they start coming off of prophylaxis, even though they're on stable immunosuppression, this is where really the risk of opportunistic infections start to reemerge. Especially if they get episodes of rejection that requires high immunosuppressive agents. And plus, they're up and about, they're traveling, visiting family, interacting with their pets. So the risk of zoonotic infections, tick-borne illnesses, and other endemic mycosis also goes up. It's usually an overlap. It's not very distinct, but, just to kind of make a point here.
All right. So, the timeline that Dr. Khalil went over on different early, intermediate, or late, usually that holds pretty well when patients are on stable immunosuppression. But if they get episodes of rejection or their immunosuppression is altered due to some reason, then the infection risk may go up and down depending on what agents are being used. So this is important to keep in mind. So for instance, if they're on steroids, which suppresses T cell activation and trafficking, then the risk of PGP goes up again. And this needs to be factored in when considered diagnostic testing or restarting them on prophylaxis. Similarly, if they get ATG, which is really like giving patients AIDS in a bottle because it completely wipes out their T cells and B cells, and then they are high risk of reactivation of viral infections such as CMV, EBV, or even PTLD due to EBV infection. Similarly, if they get CellCept, they are high risk of nocardia, listeria, and other fungal infections. So when you consider whether they're early, intermediate, or late, also factor in what immunosuppression that they're on and when did they get treated for a rejection episode, because that would help you decide whether you want to go to CMT, which will pick up the typical organisms, or Karius that'll be better at picking up opportunistic infections in these patients. And while on the subject of infections and transplants, an important factor to consider is that despite of all the advances that have been made in transplantation surgical techniques, diagnostic methodologies, and prophylactic strategies in the last 3 decades, infection remains a problem across all transplant types. If you look at the table on the top, you see in the first year after transplant and look at attributable causes of death in these patients, infection is the leading cause of death in these patients. But even if you look at long-term mortality in the next 10 years, which is in the table below, infection remains the leading cause of death in these patients. And this really highlights that we need novel diagnostic methods because infection is treatable and these deaths are preventable if you just make the diagnosis in time. So recognizing the potential of these novel diagnostic testing, especially emerging evidence for cell-free DNA, as David mentioned, the American Society of Transplantation now comments on this when this test can be used. So they highlight 3 areas where this test can be useful. One is that the infection is at a site which cannot be accessed for sampling, like a brain infection or a deeper visceral infection, or one suspects that patients are really sick and CMT is going to take longer and you need to make an early diagnosis. And that's where cell-free DNA can be helpful. Thirdly, when there's a concern for invasive fungal infection, you already sent your cultures and biomarkers and they're negative and you still are in desperate need to confirm the diagnosis. In addition, they comment that specimens can be obtained upfront so they're not affected by your ongoing empiric antimicrobial therapy, and then sent later in the course if CMT is negative. However, the problem in widespread adoption of these tests and technologies is that the evidence specific to transplant patients is not that robust. So we at St. Luke's had previously looked at our own experience from January 2017 till December 2018. And because we are the early adopters of this test, most of the other institutions started using it more and more in 2019 or 2020 and onwards. So we looked at 167 patients in that time frame where Karius was sent, and this was both immunocompetent and immunocompromised patients. And we were pleasantly surprised that 71% of the patients, something was detected on the test. So we looked at the impact of that detection on the management and found out that 72% of the patients who had a positive Karius test, it resulted in change in antimicrobial therapy across different infection syndromes, whether it was a deep-seated infection, FUO, septic shock, culture-negative endocarditis. However, when you look at the box in the red, you realize that there were only 5 transplant patients in this cohort. So therefore, this study did not give us the answer as to what is happening in our transplant patients where Karius is being sent. And that's where, the importance of this study that was led by Dr. Khalil comes in, and let her talk about it.
All right. So, this data is from our experience of using Karius in our SOT patients, and we looked at 113 adult recipients who were hospitalized between 2017 and 2023. And so we had a very diverse group of patients with recipients including liver, kidney, lungs, and hearts, but a wide variety of syndromes with which they presented, for which we sent Karius. And as I had mentioned in the earlier slides, we divided the infection into 3 timeframes of early, intermediate, and late, because we know that the microbiologic profile of each of these timeframes are slightly variable and different, and we wanted to see in what timeframe Karius would be most helpful in sending this test. Next slide.
So the first step in the study was coming up with clinical definitions for what the impact of the test looks like. And how do we know that the organism isolated on Karius is the cause of syndrome of concern? So for the clinical impact definitions, we used definitions that are published by Hogan et al. And used in other studies at the time this study was being conducted to make sure what we find is relatable and can be referenced against the published literature. So for clinical impact, we divided into 3 categories of positive, neutral, and negative. And within the positive, we have 3 major areas of impact. One is diagnostics. So a new diagnosis or an early diagnosis or confirmation of a diagnosis that was suggested by CMT but not confirmed by CMT. Then the second is further testing. So either Karius led to focused, appropriate additional diagnostic testing or was helpful in avoiding invasive interventions for diagnostic purposes alone. The third category is change in antimicrobial management. So there was escalation of care, de-escalation, or discontinuation of antibiotics if infection was ruled out. If none of these impacts were recorded in a patient, then it was deemed as neutral. And the third category is negative. So in rare situations where the test resulted in unnecessary further antimicrobial therapy or interventions that could have been avoided, that was a negative impact. Then the second table below is clinical adjudication. Now we use 3 independent ID specialists to adjudicate these cases, and they were divided into 4 categories of definite, probable, possible, and unlikely. And the reason this distinction was made is because until the time of this study, and even now, frequently CMT is considered the gold standard test and against which we are judging the importance and the validation of the metagenomic testing. So depending on whether the organism that was found in KT considered the cause of the syndrome of concern, it was divided into definite, probable, and possible, depending on correlation with CMT, whether CMT was concordant, negative, or discordant. If the organism detected in KT was considered unrelated to syndrome of concern, regardless of concordance with CMT or not, then it was classified as unlikely to be the cause of syndrome of concern. So for instance, you could find Staph aureus in sputum culture and Staph aureus in KT, but if you're looking for, let's say, a nodular cavity infiltrate, and both of these were considered unlikely cause of that, they will be unlikely despite of concordance or lack thereof.
All right, so then coming to the results, this is, I would say, a very important slide, because this is really critical, even though, when we were doing the study and using Karius before that, and we found it to be quite helpful, we weren't really sure how much it was helping us until we looked at our own data. Generally, when we, in our EPIC system, when we order the Karius, when we first send the Karius test, first of all, it's restricted to ID, so only ID can order it. And the micro lab would not process it unless ID approves it, even if they're not consulted, or if, like a primary team or the transplant team tries to send it, they'll reach out to us to see if it's appropriate or not. And then we will order it and we'll pick a specific indication based on the presentation of why the test is being sent. And this is very helpful because, we see in some practices, the tests are ordered, we don't really know why they're being sent. So then when you get a result, you don't know what you're doing with it. So the pretest probability is critical in assessing the result of the test. And you need to understand why it's being sent and how it fits with the syndrome of concern. And that's why I think one of the reasons why we really had a good positive clinical impact, because it was, used in the right patient population, deemed appropriate by ID. So overall, we're really happy to report that in half of the patients who were actually on an average of 6 days of antibiotics, Karius was still able to detect an organism, something that you would, most likely see CMT failing at and would be negative at that point in time. We had a very high microbiologic yield overall of 71% of cases having a positive test with one or more microbes, which is really good. So then if you shift the focus to the right of the slide, looking at the ring, we divided the results of the Karius test into 4 categories based on the results of the Karius in comparison to the conventional testing, because that's what we used as a gold standard for our adjudication purposes, as Dr. Sohail explained. So the first part of the ring that I want you to focus on is the orange section, where both your conventional testing and your Karius test is positive. And this is the area that gives us confidence, especially in this study timeframe, that what Karius was detecting was not just DNA of irrelevant organisms, but what we're really finding is in fact what CMT is also finding. And that was, 40% of the patients. Now, taking that confidence, we can move on to the next part, which is the dark blue section of the ring, where your Karius is positive, but your conventional testing is negative. So here we see that in 1/3 of the patients, Karius is the only test that's giving us a positive result, and CMT is completely negative for the syndrome of concern. So in your really sick transplant patients, if you didn't have Karius tests, you wouldn't really have a diagnosis, and you would be managing the patient with educated guesses, kind of going blind, which we oftenly do. So this dark blue area is really an area where Karius outperforms your conventional testing. Then if we focus on the light blue section, where both Karius and your conventional testing are negative, this is possibly suggesting that the patient likely has a non-infectious cause of their current presentation. And again, this is also very important in your transplant patients, because early distinction of infection versus non-infectious causes, such as rejection, is critical because both require timely management decisions. And knowing the limitations of your conventional testing, if that's negative and you have a negative Karius test, it gives us confidence that it can be an adjunct in helping ruling out infection. Obviously, there's no 100% way of doing that, but it still gives you that confidence. And we see the clinical utility of it here. And then finally, the small section, which is your green section, but very important, where, you know, your conventional testing is positive, but Karius is negative. So this area, you know, 8%, but I think it was like 13 patients in our study. It really makes you pause and think what's going wrong. And one has to realize, you know, like all tests, Karius is not a magic bullet, which will solve all of your problems and catch all the diagnoses. However, you know, it's for the clinicians who are using Karius to remember that the test has limitations. For instance, you know, if you have a patient coming in a viral respiratory tract infection, which are mostly your RNA viruses, Karius is not designed to pick up RNA viruses, so it would not be good to send it. You're going to get a negative test. Similarly, for localized infections like mucosal infections limited to the gut, where you may have C. diff or colitis due to some other organisms, you know, GI pathogen panel is probably preferred because you may not have systemic cell-free DNA in those circumstances circulating in the blood for Karius to detect it. So this kind of helps us think about how to send the test. Next slide. So here we just want to show a diversity of clinical syndromes for which we sent the Karius in our SOT population. And you'll see here a wide range of organisms that were detected, including viruses, bacterial infections, fungal, parasitic. A lot of them, your typical organisms. It was found to be really helpful. But then also you have your atypical and less common organisms detected as well. Next slide. Now, looking at this bar chart, you know, we really want you to focus on the correlation between the timeframes, the early, intermediate, late, when the patient presents, and the microbiologic yield of the organism, and when it translates to a positive clinical impact. So what we see in this slide, one is that overall, which is a big thing, 1 in 4 patients had a positive clinical impact. So this is really good for a novel diagnostic test. It gives us a lot of confidence because we frequently see CMT, you know, does not always translate into that. Second, the positivity of the test and the positivity of the clinical impact is, you know, the positivity of the test and positive clinical impact is variable in different timeframes. And you see the highest impact of the positive test leading to a positive clinical impact is in the late onset infections. And as we discussed earlier, this is the time frame when patients are no longer on prophylaxis. So in the late period, you get reactivation a lot of the viruses and other dormant infections that they are festering because they're no longer on Bactrim or antifungal prophylaxis or antiviral prophylaxis. And you know, you're in the environment, you can get all the mold infections, endemic mycoses, NTMs. And we know that this is really the kind of organisms that CMT also is not very good at picking. And you need early diagnosis. And so Karius is really helpful, I think, in this patient population when we see it, you know, broken down. All right, next slide.
So in this slide, we kind of break down. So Dr. Khalil mentioned that 1 in 4 patients had a positive clinical impact. And here we break down what that impact kind of looks like. So the most common, which is 56% of the patients, is a new diagnosis, which was established only based on a Karius test. And as you would expect, the new diagnosis would then lead to change in antimicrobial therapy. So that closely follows the other positive clinical impact, which was seen in 52% in patients who had the new diagnosis. Additional significant changes that were made in patient management were de-escalation of therapy in 33%. And this can happen both as a result of a positive test or a negative test where you rule out infection. 11%, there was avoidance of invasive interventions such as bronchoscopy or deeper biopsies. And Besides that, earlier diagnosis was also a major impact, which was seen in 26%. And lastly, confirmation of clinical diagnosis. So there are times you detect an organism on CMT, but you're not really sure is the cause of syndrome of concern. So you may have a positive sputum culture, patient coming with lung infection, and you're not sure if what you found, few colonies of X, Y, and Z organism, the sputum, is necessarily the cause of infection, but having a positive Karius with high MPM now pushes that suspected organism into definitive category of a real infection, helpful in making clinical interventions.
We go back to our case of this lady who had a lung transplant, who presented with, acute CVA, had elevated cell counts in her CSF, but negative cultures, and then recent history of coag-negative staph bacteremias. All right, so based on the polling for this test, this question, up to half of the audience chose sending Karius testing, which is great. And then another 38% recommended sending ME panel. All right, can we show the answer? All right, so this patient, ended up having exophiala dermatitis, which is a mold infection. And we actually weren't really expecting it. We knew this was an atypical presentation. So interestingly, when we saw this, it really, got us getting the patient on ambisome and dual antifungal coverage. This is one of the areas where Karius is quite promising, which is your fungal infections. And these are frequently not picked up by your cultures or serologies. And so timing of diagnosis is of the essence in how you manage these patients.
All right, so now we come to the case 2 that I had initially shared. Just to recap, it's a 52-year-old female with kidney transplant, comes with recurrent UTIs, got some antibiotics before hospitalization, so has negative blood and urine cultures, has new back pain, MRI shows discitis, and we discussed what kind of testing you would do at this time. All right, so it's quite interesting. So in the beginning, when we asked the question, there was a even 1/3 split. 1/3 said that they want to go for a biopsy, 1/3 wanted to send Karius right away, and 1/3 wanted to wait for the biopsy report before they send Karius. And after the polling, we have managed to sway many people to sending Karius early on as the frontline test. Now, this is an area where I really wanted to highlight that Karius and CMT are not exclusive, where you have to choose between one or the other test. They have both their strengths. So in this particular case, Karius was sent initially because patient did not want the spine biopsy. And within 48 hours, we found out this patient had Pseudomonas with high MPM. Patient was on ceftriaxone and vancomycin initially empirically because Pseudomonas was not detected previously in previous urine cultures, so it wasn't thought about. And once this result came back, patient was started on meropenem on day 3. But on day 2 of the hospital stay, patient also agreed for the biopsy. So it was sent on day 4. And fortunately, usually you would expect that the cultures would be negative by this time, but we were able to grow Pseudomonas 3 days later. So now this is hospital day number 6, that the Pseudomonas is growing from the biopsy. On day 7, we have susceptibility report, which shows that it's resistant to cefepime and fluoroquinolones, the antibiotic patients have received in the past, but sensitive to carbapenems and other antimicrobial agents. So here you see the benefit of both tests in their own rights. First of all, if we did not have Karius, this patient would still be on ceftriaxone and vancomycin, which would not cover the Pseudomonas. For the whole week, patient would be on wrong therapy, with the swine infection, with the risk of progression of infection, getting paralyzed because we didn't give her the right antibiotics. But at the same time, the biopsy and cultures were helpful because this patient required long 6 to 8 weeks course of IV antibiotics. And if we did not have full susceptibility profile, we would not really know which long-term antibiotics to use, and if you're able to de-escalate, or we're stuck with carbapenem therapy, because antimicrobial resistance markers in gram-negatives are limited to ESBL and KPC, but do not necessarily detect cefepime resistance or fluoroquinolone resistance.
All right, so here we have another case in which we want to highlight a really important point. So we won't do polling on this one, but just briefly going over the case. This is a patient who underwent a kidney transplant several years ago, who's on stable immunosuppression. And he comes in with fevers, low-grade fevers of several weeks with a normal white count, slightly elevated sed rate. Had a basic workup done with blood urine cultures that were negative. He got a chest x-ray that was clear and was treated with a short course of antibiotics. And, the fever's resolved, so he's discharged. And then he represents another, like a week later, reports recurrence of fevers, now also reporting mild headaches. Maybe also he's now noticed that he's had a 10-pound weight loss over the last several weeks. And so he gets imaging this time, which is negative. They do a standard of care workup, which is all negative. And so finally they end up sending a Karius test. He is found to have a Bartonella infection. So, we've all been in this situation in our practice frequently where you have a patient who has vague symptoms, low-grade fevers, and you send your fellow with a list of questions to look for exposures, and usually the patient denies them. You examine them, you don't find anything, you scan them, do all the standard of care workup, and you don't find an organism. You don't really know what's going on. So what do we do in these cases? Next slide. We basically go on a fishing expedition, and we start ordering all these tests, for looking for different organisms. And in each hospital stay, many times on average, we end up ordering 15 to 20 different tests throughout the course of their hospital. And they all have different turnaround times. They get sent out to reference labs. So you spend several days doing several different kinds of workup, waiting for the test to come back, not getting an answer, and possibly by that time, the patient's not on the right antibiotics because we still don't know the cause. So here, I just wanted to share this data from Mayo, where they specifically looked at this issue of FEO and Karius testing. And we clearly see in these tables that despite of, thinking about exposures and doing all these tests, they're negative in 90% of the cases. So they're not really helpful, even though we think that they may be. And so there's a good chance that at the end of the week, you not only do not have a diagnosis, but the patient's been in the hospital for 7 days. So the point that I'm trying to make here is the overall cost. And I want to address this issue because, when a lot of times, and I've seen this in practice and in discussion with people from other institutions, that we start to get focused and fixated on the cost of a singular test. And what happens is that you get so close to the tree that you lose sight of the forest. Because what else is happening? In addition to ordering the battery of tests, you're also thinking about invasive diagnostic procedures, and the patient, ends up being in the hospital for several days, where the cost of the bed, the facilities, the nursing staff, it all adds up. And depending on which floor you're on, whether it's a hospital floor bed or ICU, that per day cost for that is, from $2,000 to $4,000, $5,000, $6,000. And so at the end of it, you may, I'm just thinking of a figure off the top of my head, end up spending $20,000, which is not only a burden to the patient, but to, the healthcare system as well. And you don't have an answer. So when you put that in contrast to Karius in the right patient population, the balance doesn't seem so bad. You'll have an earlier diagnosis. You may end up saving $10,000, $50,000. And that's where you really need to figure out when to send the Karius test and look at the overall picture as opposed to, individual test costs.
All right, so before we end our presentation, we wanted to go over some take-home points that once you leave the webinar and you see your next patient with infection and transplant, what scenarios you should consider sending a Karius test, because this is the high risk situation and your pretest probability of finding something in Karius is higher. So one, our patients are febrile for 48 hours with negative conventional workup. Second, if they have a suspected deep or systemic infection where biopsies are not feasible or patient refuses. Third, patient has negative cultures due to prior antimicrobial exposure. Fourth is that the timing of essence. You want to make an early diagnosis because you want to take an action. So even though you suspect the CMT may be able to find that NTM infection or fungal infection or a bacterial infection, it's just going to take days or weeks to find the answer, and you want a quick answer. And finally, when you have high uncertainty syndromes, for instance, pneumonia, especially invasive fungal infection in immunocompromised patients, FUO, CNS infections where taking biopsy samples is difficult or high risk, and intra-abdominal infections.
All right. So, this is something that we're now working on based off our study. Like we mentioned, there was a lot of variation that we found. There were a lot of syndromes that we were looking at, but we don't have, the patient population was so small. So now we are hoping to answer a lot of those questions of when to send the Karius and which patient population, what syndrome. So in collaboration with multiple large academic practices, we've put together this retrospective registry, which is nationwide, spanning from the East to the West Coast, involving almost, I think, 19 institutions. And this is important because it includes diversity of the patient populations, the different epidemiologic and environmental exposures, a wide range of transplant practices, and different prophylactic protocols. So we'll really, get down to the bottom of these questions for when to send the Karius test in SOT patients. And I really want to thank my mentor, Dr. Sohail, in helping me design these multi-center studies. And then definitely Nibum and David for providing their insight on how the Karius test works. Thank you all so much. Now I'll open the floor back to David for questions.
Thank you both. I mean, this was an excellent presentation and extremely informative. I think all of us are very excited about this very large retrospective registry, which I think will be the largest in plasma microbial cell-free DNA, and hopefully answer some questions or hopefully get similar results to what you guys found at your single center study. We had a lot of questions come in, as I anticipated, with only about 5 minutes left. So we'll try to get to as many as we can. And if not, we can respond to some of you by email. The first question that we'd like to discuss would be how do antibiotics impact the sensitivity of the test, and can you still detect microbial cell-free DNA when the patient's on antibiotics? What's your experience?
All right, may I answer this? Okay, so overall, I sense is that even if we focus on our own data, where we showed that 50% of the patients were on broad spectrum antibiotics, and even at a median of 6 days and later, Karius was able to detect the culprit organisms. And that's overall, including all syndromes. For some specific syndromes, for instance, when we look at data from Duke for endocarditis or Mass General for CIED infections, we feel that, for endocarditis data from Duke, after like even 30 to 35 days, the microbial cell-free DNA was still detectable in these cases, where blood cultures became negative on an average of like 4 to 5 days. So we feel that for all kind of infections, pneumonias, UTIs, or visceral infections, 4 to 7 days on average, you can still positive Karius test. But for deep infections, for example, endovascular, it could be weeks that you can have a positive test.
Great. So next question is kind of around that same topic. We had a question around sort of the quantification, the burden of plasma microbial cell-free DNA there, the higher amount And is there a way to use this to monitor response of therapy? Can it predict a worse infection in a patient?
All right. So, in our experience, we don't routinely use it for serial monitoring. However, there is some data in cardiovascular infections or invasive fungal infections, even though those are not large studies, that the organism burden can be helpful to detect response to therapy. And this can be really important, as Dr. Khalil had mentioned during her presentation, that when you have patient with, let's say, invasive fungal infection, you start them on the appropriate antifungal therapy. And the problem, of course, is we don't have antifungal susceptibility report with Karius, and frequently CMT is negative. So you don't know with certainty if the organism is susceptible to the antifungal drug that you're using. So a week later, 2 weeks later, a patient has an episode of fever, we get rescanned, you find the same infiltrate, sometimes it looks a little worse, and you're trying to figure out like what happened here. Is the infection getting worse? Is it progressing? Is it fluid overload or a bacterial pneumonia on top of that? And that's where I think organism burden can be really helpful to detect a response. So if the MPMs are going down, then probably your invasive fungal infection is well controlled, and you don't need to necessarily rebiopsy or reculture or double down on your antifungal therapy. Similarly, this was very promising data from Mass General. It wasn't focused on transplant patients, but it was on CIED infections, where they monitored serially and were able to exclude some of the patients who did not truly have lead endocarditis. And if Karius was routinely used in such patients, potentially an unnecessary device removal could be prevented in those cases.
Thanks. Can you elaborate a little bit more on negative predictive value? And I know what you guys had discussed in your study, there were 21% of patients that had negative plasma microbial cell-free DNA test and a negative conventional test. The question is really, can you use this test for a negative predictive value?
I think that it really depends on the presentation of the patient, the clinical context in which you're using the test. So a lot of times, they're critically ill, but your suspicion of infection is low. And the test on its own is not something that you would use to rule out infection per se. But if they have, the conventional testing is negative, overall suspicion is low, then the Karius can give you confidence that, infection is now less likely because the patient's been on antibiotics for days, they're not improving, you have a whole spectrum of tests that are negative, and then a highly sensitive test that's coming back, 100% rule out or a high negative predictive value, depending on the circumstances, would be with how the patient presented.
Thanks. And then lastly, I know we only have a minute left, but can you comment a little bit more on timing? I think one of the participants was a little confused in thinking that maybe the test should be ordered late in treatment based on some of the things that maybe were mentioned during the presentation. Can you comment on that a little bit?
Do you want to take this, Dr. Sohail, or should?
Yeah, I can comment on that. So, in terms of timing, it all goes back to the same concept of pretest probability, that if you suspect a typical bacterial infection, which, as Dr. Khalil mentioned, happened during early post-transplant period, then it's perfectly reasonable to send your standard of care testing up front and only send Karius 2 days later if the standard of care testing is negative. On the other hand, if you suspect this opportunistic infection, you already know that your CMT is either going to be negative or it's going to take days and weeks to get the results. And therefore, you should, probably send Karius up front while you pursue your targeted CMT in addition to that, if necessary.
Great. Well, I want to thank you, Dr. Khalil and Dr. Sohail, for your presentations today.